All right, good afternoon, everyone. You're at your final countdown. We're gonna close shop very soon. This topic is actually very vast and very important. But I'm gonna try to make it bite-sized so that it's very practical and hopefully you have some use from what I talk about. So the goal with this talk is really to review the risk of infections by class of immunosuppressant therapy first, then to go over specific infections to recognize, and then also how to minimize risk of infections. So when talking to your patients, and also based on the literature published so far, infections can be categorized in different classes. There are benign infections, which are the most common. This can be like sinus infections, oral herpes, for example. Serious infections, these are infections that require hospitalization, and opportunistic infections, and these are infections that affect the immunocompromised. So when I talk about the medication classes going forward, I'm gonna try to break it down into those categories. And the data is basically few in terms of quantitative data. There's a lot of qualitative data. But I was very lucky because recently there was a study published in Gastro which helped actually add to the information that we have for infections, especially serious and opportunistic infections. So starting off with anti-TNF therapy, the most common infections are benign infections. So this includes upper respiratory infections, urinary tract infections. A lot of this data came from clinical trials, as well as the TREAT registry, which is a long-term safety registry for infliximab. So really those are the most common infections for anti-TNF therapy. Well, how about serious infections? Well, you've heard already over the past few days about this study out of Gastro. It's a French population study looking at serious and opportunistic infections in the population. So with anti-TNF therapy monotherapy, the risk is about a little bit less than 2% per year for serious infections. When you add a thiopurine to that, it goes a little bit more than 2% per year. The most common serious infection actually was pneumonia, but all risk categories were increased with anti-TNF therapy. And to kind of elaborate on Tina Ha, who just spoke, patients over age 65 were also found to have a higher risk of infection. And this was with monotherapy or even combo therapy. Well, how about other studies? Well, there's the TREAT registry, which also looked at serious infections, similar types of infections found, and also older age was associated with a higher risk of infection as well. How about opportunistic infections with anti-TNF therapy? Well, the risk is less than for serious. Now we're talking about 0.2% per year for monotherapy. If you add a thiopurine to the anti-TNF therapy, now you're going up to 0.4% per year. And all types of opportunistic infections were increased, but it did not meet statistical significance for fungal infections. And this may have to do with the fact that, maybe in France, there's less fungal infections. Probably not, but fungal infections may vary based on location of practice or where we're seeing our patients, just as in the United States. With the TREAT registry, in terms of types of opportunistic infections, herpes zoster, serious cases of TB, as well as histoplasmosis, in one case disseminated. And then a colleague of mine actually published a study recently based out of the VA system showing that anti-TNF therapy alone was not associated with herpes zoster. So there may be, there may be a slight risk of herpes zoster, but not as much as the next class of medications, which are thiopurines. And thiopurines include azathioprine and 6-mercaptopurine. And really the theme with thiopurines, in one sense, is really the risk for herpes zoster, whether it's benign, serious, or opportunistic. And other infections that are also increased include herpes, herpes flare-ups, as well as the increased number of warts based on an outpatient study. So serious infections, what's the rate? Based on the French study, it was about 1% per year, but it was less than that for an anti-TNF. And then for opportunistic infections, the theme again is viral infections predominate, but overall with thiopurines, there is an increased risk of infections in general. As far as mortality, with anti-TNF therapy, so far no increased risk of mortality that we know of. With thiopurines, the same, but there are case reports of severe fatal infections, such as that of CMV and EBV, leading to cases such as HLH infection. Well, how about natalizumab? Well, natalizumab is an alpha-4 beta-7 beta-1 antibody causing immunosuppression in the brain and in the GI tract. Based on the clinical trials for natalizumab, there was an increased risk of nasopharyngitis and even maybe the flu based on the clinical trials for IBD. But of course, the most serious infection that you hear about with natalizumab is really the concern for PML due to JC. And risk factors other than being JC positive include long duration of treatment for more than 2 years, being on prior immunosuppressants. These really increase your risk. Based on data from August 2015, the risk of PML was about 1 in 238. But if you're anti-JC antibody negative, the risk is less than 1 in 1,000 risk. There's also post-marketing data for other serious infections with natalizumab, including herpes encephalitis and meningitis, and something called acute retinal necrosis, which is a viral infection caused by herpes. How about vedolizumab? So this is a gut-selective alpha-integrin antibody. Again, with this class, there's a slight increased risk of nasopharyngitis again, with a slight trend of more upper respiratory type infections, influenza, sinusitis as well. How about serious and opportunistic infections? Well, so far, no increased risk that we know of based on the clinical trial data. But there may be a trend towards slightly more GI infections such as C. diff, CMV, but still not statistically significant. Also, no cases of PML so far that are completely attributable to vedolizumab. Well, how about istakinumab? So far, based on the trials published, no increased risk of infections overall, but based on the psoriasis trials, these included other IL-23 pathway drugs. Based on a meta-analysis, there was no increased risk of infections, and this is based on dosing, though, of 90 milligrams every 12 weeks. Of course, with istakinumab, there have been case reports, of course, of infections such as reactivation of latent TB, herpes zoster as well. How about tofacitinib? You've been hearing a lot about tofa throughout this conference, with the theme being, the risk of herpes zoster with it. And based on the clinical trial data, and there was actually a recent publication by Sanborn, basically accumulating all the data from the clinical trials and open label studies, showing that, yes, the risk of herpes zoster is increased. It seems to be dose dependent as well, so it's higher risk with the 10 milligram BID dosing. And the risk can also increase your risk for opportunistic infections related to herpes zoster. So there's a higher rate of other things such as ophthalmic herpes zoster, and there was one case of herpes meningitis as well, herpes zoster meningitis. But most of the cases were cutaneous. Also, with TOFA, there is a slight higher risk of nasopharyngitis and upper respiratory infections. How about corticosteroids? So Dr. Ha also mentioned corticosteroids as an evildoer for our older patients, which is true. Corticosteroids is associated with a higher risk of mortality overall with its use, and specifically also higher risk of infections in the elderly. What are the types of infections? For benign infections, we're talking about herpes zoster increased risk, maybe not as much though as thiopurines and TOFA. And overall, serious infections are increased. This includes even C. diff, which you heard also from Dr. Binion, and post-op infections, actually. This is something that we published several years ago. And then the other thing is with long-term steroid use and high-dose steroid use, there is a concern for PCP pneumonia This risk increase can go up tenfold with steroids, although the risk of PCP pneumonia in general is low. But it is recommended that for those patients on high-dose steroids for at least 8 weeks, and another society recommends greater than 20 milligrams for at least 4 weeks, consider prophylaxis. And I'll talk about PCP a little bit later, but there are also other recommendations from GI general consensus. How about some of the other medications that we use to treat? How about methotrexate, for example? Well, in the IBD literature, there's actually limited data. In the non-IBD literature, there does seem to be a higher risk of infection overall, with case reports of opportunistic infections. How about cyclosporin? The same is true in the IBD literature, but definitely opportunistic infections reported with PCP, aspergillus. And as we know, even fatal infections, when we start accumulating meds, cumulative meds, cyclosporin, steroids, azathioprine, our hospitalized patients, there's even a risk of death. So what are the specific pathogens? So what do you guys think in terms of class of pathogens? My topic actually was viral, bacterial, or fungal infections. What are the most common? Of those categories, how many think bacterial infections are most common? Okay. How about fungal infections? How about viral infections? Okay, so yes. So the most common infections actually are viral infections, with especially the meds that we use. Now, when we're talking about the data to show this, there is limited quantitative data. There's a lot of qualitative data showing kind of the prevalence of viral infections and infections overall. But based on the outpatient data that we have for benign infections, herpes zoster is increased, followed by herpes simplex, HPV, and I had to include upper respiratory infections as well, because many upper respiratory infections are viral, but they're not necessarily specified in terms of what the pathogens are. Based on the French study, they also looked to see what was most common, and the most common opportunistic infections were viral. Again, these are serious infections, so these are hospitalized-based patients. And the most common was CMV, HSV, EBV, viral meningitis, viral pneumonia, acute viral hepatitis, and there was one case of PML. So to elaborate on specific infections, herpes zoster, as you've heard already many times, but the presentation can be of a blistering vesicular rash in a dermatomal pattern, and this is basically reactivation of varicella. What's interesting is that you can have also symptoms preceding it, which include pain, itching, or tingling, which may occur days to weeks prior to even having the rash. And the rash can also disseminate, especially in patients that are on immunosuppressants. Risk factors include thiopurines, as you've heard, corticosteroids, tofacitinib, and an age over 50. What's also interesting is that patients with IBD specifically are maybe even at increased risk even without being on immunosuppressants. And it seems to affect all age groups with IBD. And in a Korean study that was just published, the median age of herpes zoster was 36 years old. But the guidelines right now for prevention for herpes zoster is basically, giving a vaccine for patients over age 50. Right now we're recommending Shingrix because it's not live, but in the future we need to consider maybe, vaccinating our younger patients as well and having more data in that population. Patients that receive herpes zoster, it's 2 doses, 2 to 6 months apart. They can receive it if they've had zoster before or if they've had Zostavax, which is a live vaccine, but it's not recommended for those that are seronegative to varicella. How about HPV? Well, HPV is also pretty prevalent in our population, about 20 to 40% prevalence in adults. There are over 100 types of HPV, with high-risk HPV causing cancers such as cervical cancer, and there's lower-risk HPV as well, which can cause genital warts, for example. In the IBD population, worsening of warts can occur with thiopurines, and there's a possible increased risk of cervical dysplasia as well in women with IBD. So there is a 9-valent HPV vaccine, and right now the age has been expanded to up to age 45 for both men and women, actually. So how about herpes simplex 1 and 2? This is also a very prevalent virus and can cause complications in our immunosuppressed patients. The prevalence is about 90% by age 40, can cause oral genital ulcers, and as mentioned, with immunocompromised patients, it can cause disseminated disease, meningitis, encephalitis, pneumonia, GI infections, and hepatitis. Diagnostic tests include culture, PCR, as well as serology. And treatment is generally with acyclovir, IV if it's severe. Oral valcyclovir is also an option when it's not severe. And for those patients on immunosuppressants that are getting recurrent flares, consider prophylaxis in those patients. How about cytomegalovirus, CMV? Well, the prevalence of CMV is about 40 to 100% in the general population and becomes activated on immunosuppression. It can cause a flu-like syndrome. It can also cause hepatitis, and as well as you know, CMV colitis as well. And in the steroid refractory patients, CMV prevalence can be as high as 32% in a study published in 2008. So diagnostic testing is based on the location of where you suspect the CMV to be. So if it's in the GI tract, of course, you're going to be doing an endoscopic procedure, but if somewhere else, then you may be doing serum CMV to help detect. And treatment is with IV ganciclovir or oral valganciclovir. So what are the most common bacterial infections? Again, based on that French study that was published this year, bacterial infections were the second most common opportunistic infection. What were they? Included Mycobacterium infection, strep pneumoniae, Salmonella, Legionnaires, and Listeriosis. And also what's common is C. diff, as you've heard from Dr. Binion. Streptococcus pneumonia is the most common community-acquired pneumonia. It can cause meningitis and bacteremia, and risk factors include being over age 65, having a chronic illness, and being on immunosuppressants. And you've heard already at this meeting of the vaccines that are available for this. This includes the 13-valent pneumococcal vaccine and the 23-valent pneumococcal vaccine. And both are recommended for our patients on immunosuppressants that are over age 18. If they haven't received either one, it's recommended to get the 13-valent first. Mycobacterium tuberculosis, what's the concern here? Well, if someone has been exposed to TB and then they're treated with an anti-TNF, there's a 5-fold increased risk of reactivation in the first year of using an anti-TNF. And reactivation cases may not be necessarily pulmonary. They can be extrapulmonary or disseminated. So we need to screen our patients prior to starting medications such as anti-TNFs and even other biologics. What's recommended, as you've heard, TST testing, interferon gamma release assay testing, and consideration for even a baseline chest x-ray based on the ACG recommendations that had just come out. How about what to do if someone has latent TB? They tested positive. What are you going to do for those patients? Well, some guidelines suggest maybe starting chemoprophylaxis 1 to 2 months prior, but in general, even in my institution, sometimes we get the ID docs involved to help decide on that right time frame. And while on immunosuppressant therapy, the question becomes how often to rescreen our patients for exposure to TB. The optimal screening is not yet known, how often, but the goal is that one should probably rescreen at some point. C. diff infection, as you've heard from Dr. Binion in great detail, in patients that flare, 26% of those patients, it's because of an enteric infection based on a recent study that was published, and the most common infection was C. diff. And risk factors for this include colonic involvement, corticosteroids, antibiotics, as you've heard, and also increased mortality and higher risk for surgery, longer hospitalizations for our patients that have this. Diagnostic testing, as you've heard, it's 2-step that's preferred rather than 1-step NAT alone due to the concern for colonization. And the treatment now is first-line, non-severe cases, vanco or fidaxomicin, and not metronidazole. Severe cases, vanco plus maybe consideration for IV metronidazole. And then last category that is very significant but not necessarily most common are fungal infections. And based on a systematic review of studies published of fungal infections in PubMed, the most common ones were Candida species, mostly the GI site, histoplasmosis, Pneumocystis, Cryptococcus were most common. And then in the French study, Candida, Aspergillus, and Pneumocystis. So Pneumocystis, as you've heard, is basically a fungal infection that increases with being on multiple immunosuppressants, as well as being on long-term steroids, and actually also being lymphopenic. The presentation generally is a cough, fever, and shortness of breath, and tests include chest x-ray, CAT scan as well, and a lot of times you're gonna also have to obtain a sputum for diagnosis. Treatment is with IV trimethoprim sulfamethoxazole, and expert opinion right now in the IBD world and GI world is that if you're on triple immunosuppressants, consider prophylaxis, especially if it includes an anti-TNF or calcineurin inhibitor. The concern with pneumocystis is that it's also associated with a high mortality, 20 to 60%. Histoplasmosis is also of concern in the United States. It's endemic in the Midwest, where there's a higher rate of that. Risk factors include immunosuppression and being exposed to soil that has histo. Presentation can be pulmonary or disseminated, and diagnostic tests include fungal cultures, histoplasma, urine, and serum antigen, and serologic testing. Treatment is basically, in severe cases with ampho, with mild cases, ITRA, and actually treatment can last up to a year. Prognosis also 20% mortality in the anti-TNF treated. So to summarize, how to minimize risk in our patients. Well, you've heard already in this conference, vaccinations are important, and also making sure that vaccinations in our healthy patients, even before they are on immunosuppressants, make sure those are updated. Prior to an immunosuppressant, also make sure they're updated, and then also consider vaccines such as the pneumococcal vaccines. If they're gonna go on Tofa, consider Shingrix if you can get it. You may not, if someone really needs Tofa and you can't get it, you may need to start the Tofa. If you don't know their status for varicella or MMR, consider those vaccines, but they are live, and so they should not be started on patients on immunosuppressants. And while on immunosuppressants, no live vaccines. And then we should also be screening our patients for infections prior to going on biologics. And you've heard of those: TB, Hep B, Hep C between patients born between 45 and 65, 1945 and 65, consideration for HIV even, and then JC for natalizumab, and consideration for prophylaxis if patients are on steroids for a long period of time, high dose, and if they have HSV with frequent flares. So take-home points. Benign infections are really the most common infections with the meds that we use. They include sinus, upper respiratory, nasopharyngitis, and UTIs. And serious infections are really rare, less than 2% per year, and associated with corticosteroids, thiopurines, tofa, natalizumab, and anti-TNF therapy. And the risk does increase with combo therapy, thiopurine, and anti-TNF therapy. Opportunistics are the most rare, but can be serious and should be recognized early for detection and treatment. And also minimizing risk includes updating vaccines, screening for infections that may reactivate, and considering prophylactic therapies. So thank you very much.